Good morning, and thank you all for being here today. My name is Careen Tetuh. I'm a DMP student at Maryville University, and I'm honored to present my Doctor of Nursing Practice Scholarly project titled Improving Dictation of Depression and Suicide Risks by Implementing a Standardized PHQ-9 Depression Screening Protocol in Primary Care. This project was completed at Quick Clinic Medical Center in Rosenberg, Texas, a federally qualified health center serving predominantly uninsured and Medicaid-eligible adults. The work reflects a critical need in primary care, improving early identification of depression and suicide risks through systematic, evidence-based screening. Today, I will walk you through the background, purpose, methods, results, and implications of this quality improvement initiative and demonstrate how standardized screening can meaningfully strengthen patient safety and mental health outcomes in underserved populations. Community members. I would like to acknowledge and thank my community members for their guidance and expertise throughout this process. My chairperson, Dr. Rachel Davis Citron, provided invaluable mentorship in shaping the project's clinical relevance and methodological rigor. My second reader, Dr. Dawn Matz, offered thoughtful feedback that strengthened the clarity and structure of the work. And my community member, Dr. Oluma Okondeye, contributed essential psychiatric and clinical insight that enhanced the project's real-world applicability. Their collective support ensured that this project met standards of a doctoral project and contributed meaningfully to primary care practice. Background and significance. Depression remains one of the most common yet under-recognized conditions in primary care. Many patients present with somatic complaints, fatigue, pain, sleep disturbance, rather than explicitly reporting mood symptoms. Without routine screening, these cases are frequently missed. At Quick Clinic Medical Center, there was no universal depression screening workflow for adult visits. As a result, opportunities for early detection were inconsistent, and suicide rates was not systematically assessed. The aim of this project was to implement PHQ-9 as a routine screening tool for adults aged 18 to 65. The purpose was to improve detection of depression symptoms, identify suicide-related concerns through Item 9, and strengthen behavioral health referral pathways. Given the high burden of depression, especially in underserved communities, implementing a standardized, validated tool like the PHQ-9 is both clinically necessary and aligned with national recommendations, including the U.S. Preventive Services Task Force. Pick-up question. The pick-up question guiding this project was, in adults aged 18 and older in primary care, does implementing the PHQ-9 screening protocol help dictate and identify depression and suicide risks compared to not using PHQ-9? This question reflects a practice gap rather than a research hypothesis. Focus was on improving workflow, documentation, and clinical processes. The PHQ-9 was selected because it is validated, brief, and practical for primary care, and because Item 9 provides a structured way to identify patients who may require immediate safety evaluation. The PCOG framework helped guide the project's design, data collection, and evaluation of outcomes. Review of literature. The literature consistently shows that primary care is the first point of contact for most adults with depressive symptoms. Yet, screening rates remain low, and diagnosis often depends on provider discretion rather than standardized processes. Evidence strongly supports systematic depression screening when workflow systems are in place. The PHQ-9 is one of the most validated tools for this purpose, with high sensitivity and specificity for major depressive disorder. Studies also highlight key implementation factors, staff training, EMR funds, and clear referral pathways significantly increase screening completion and follow-up. Barriers identified in the literature include inequities in access, cultural stigma, and inconsistent provider response. These barriers are especially relevant in underserved populations like those served at Quick Clinic. Overall, the literature supports the need for structured, workflow integrated screening to improve early detection and reduce disparities in mental health care. Theoretical framework. This project was guided by Donabedian's Quality of Care Framework, which evaluates healthcare quality through three components: structure, process, and outcome. Structure included staff education, EMR integration, and clinic readiness. These foundational elements ensure that the clinic had the capacity to implement screening consistently. Process involved routine administration of the PHQ-9, accurate scoring, and provider review during the visit. This step operationalized the screening protocol into daily practice. Outcomes focused on measurable improvements, increased screening completion, identification of depression symptoms, and documentation of follow-up actions. Methods and design. This was a quantitative quality improvement project using a retrospective pre- and post-implementation chart review. The design captured real-world workflow changes rather than testing causality. The total of 100 identified charts were reviewed, 50 before implementation and 50 after. The focus was on documenting changes in screening completion, PHQ-9 scores, Item 9 responses, and referral activity. Descriptive statistics were used because the sample size and distribution did not meet assumption for inferential testing. This approach aligns with quality improvement methodology, which emphasizes practical improvement rather than just hypothesis testing. IRB approval was obtained from Maryville University, and all data were handled in accordance with ethical standards for quality improvement work. Setting. The project took place at Quick Clinic Medical Center, a federally qualified health center in Rosenberg, Texas. The clinic serves a predominantly uninsured and Medicaid-eligible population, many of whom faced socioeconomic barriers to mental health care. Primary care is often the only point of contact for these patients, making standardized screening especially important. The clinic's patient population includes individuals with chronic conditions, limited access to specialty care, and high psychosocial stressors, all factors associated with increased depression risks and suicide. This setting provided a meaningful opportunity to improve early detection and strengthen safety practices for a vulnerable adult population. Sample. The final analytic sample included 100 adult patient charts. 50 charts were reviewed pre-implementation and 50 post-implementation. The sample was predominantly female at 68%, with 32% male. Racial and ethnic representation included 52% white, 28% black, 12% Hispanic/Latino, and 8% other. Chronic medical conditions were documented in 42% of charts. These demographics reflect the clinic's typical adult population and support the relevance of depression screening, as chronic illnesses and social vulnerability are known risk factors for depression and suicide risks. The sample size was appropriate for a quality improvement project focused on workflow change and descriptive outcomes. Interventions and implementation. The intervention involved integrating the PHQ-9 into the clinic routine workflow for eligible adult visits. Staff received training on administering the tool, scoring it accurately, documenting results in the EMR, and understanding referral expectations. Providers reviewed PHQ-9 scores during the visit, which ensured timely response to elevated scores. Special emphasis was placed on item 9, which assesses thoughts of self-harm or being better off dead. A positive response required immediate provider evaluation and safety planning. This structured approach ensured that screening was not merely completed, but meaningfully integrated into clinical decision making. Data collection. Data were collected through retrospective review of 100 de-identified electronic medical records. Variables included screening completion, PHQ-9 total score, item 9 response, and referral documentation. Inclusion criteria were adults aged 18 to 65, seen for routine or chronic care visit. Exclusion criteria included a documented history of depression or suicide risks and patient under 18. PHQ-9 was the primary instrument. Scores were categorized using standard cutoff: minimal, mild, moderate, moderately severe, and severe depression. Item 9 was treated as a critical safety indicator requiring immediate provider action. Data were organized in Excel and analyzed using SPS version 29. Data analysis. Descriptive statistics were used to analyze the data. Frequencies, counts, and percentages were calculated to summarize outcome. Inferential statistics were not applied due to sample size and quality improvement nature of the project. This approach ensured transparent and appropriate interpretation of findings. Results. Screening completion. Screening completion increased dramatically after implementation. Pre-implementation, only 16% of charts had documented depression screening. Post-implementation, this increased to 86%. This represents a 70% percentage point improvement and demonstrates the effectiveness of structured workflow integrated and staff training. The increase reflects not only improved documentation but also improved consistency in identifying patients who may require further mental health evaluation. Results. PHQ-9 score distribution. Among the 43% screened post-implementation, 16 had PHQ-9 scores of 10 or greater. This represents 37.2% of screened patients. A score of 10 or higher suggests clinically meaningful depression symptoms requiring further assessment. Without standardized screening, many of these patients may not have been identified. These findings highlight the importance of routine screening in uncovering symptom burden that may otherwise remain unaddressed. Results. Suicide risk signal. 5 of the 43 screened patients endorsed item 9, including thoughts of self-harm or being better off dead. This represents 11.6% of screened patients. Each positive response triggered immediate provider review and safety-focused follow-up. This underscores the value of item 9 as a structured mechanism for identifying suicide-related concern within a depression screening tool. Importantly, this project did not implement universal suicide screening. Rather, item 9 served as a clinical approach as a clinically appropriate safety indicator within the context of depression screening. Results. Referral and workflow. Post-implementation charts showed more consistent documentation of depressive symptoms and follow-up actions. Providers used PHQ-9 results to guide behavioral health referrals and safety evaluations. The workflow created a clear pathway: screening, provider review, and referral or follow-up planning. This strengthened the clinic's ability to respond to mental health needs during routine visits. These results suggest that structured screening not only identifies symptoms but also improves the continuity and quality of care. Limitations. This project had several limitations. First, it was conducted at a single site, which limits generalizability. Second, the retrospective chart review depended on the accuracy and completeness of EMR documentation. Third, the sample size was appropriate for quality improvement but insufficient for inferential statistical testing. Finally, the project did not track long-term treatment engagement or patient outcomes beyond the initial visit. Despite these limitations, the project provides meaningful insight into workflow improvement and screening effectiveness. Discussion. The findings demonstrate that routine PHQ-9 use significantly improved documented screening in primary care. A substantial proportion of the patients screened had elevated scores, and item 9 responses highlighted the importance of structured safety follow-up. The project supports the literature showing that standardized screening improves early detection and reduces reliance on provider discretion. It also reinforces the need for integrated workflow, staff training, and clear referral pathways. Overall, the project strengthens the clinic's capacity to identify and respond to mental health needs in an underserved adult population. Implications for practice. This project has several implications for practice. First, standardized screening enhances early recognition of depression, especially in underserved populations. Second, APRNs are uniquely positioned to lead workflow change, staff education, and care coordination. Third, routine PHQ-9 use supports consistent documentation and informed referral decisions. Finally, integrating mental health screening into primary care promotes safer, more holistic, and patient-centered care. These implications align with national priorities and support ongoing quality improvement efforts. Conclusion. In conclusion, implementing the PHQ-9 significantly improved screening completion from 16% to 86%. The project identified patients with elevated depressive symptoms and suicide-related concerns who may otherwise have been missed. The initiative strengthened clinical workflow, enhanced provider response, and improved documentation. Future work should focus on sustainability, full compliance, and tracking long-term outcomes such as treatment engagement and symptom improvement. This DNP project enhanced my leadership skills, strengthened my evidence-based practice competencies, and deepened my understanding of systems-level change in primary care. references. Thank you all for listening, and God bless you all.